Echo in here. Y'all can hear fine now? Okay, good. So those I've not had the pleasure of meeting, I'm Thomas Parham. I am the Vice Chancellor for Student Affairs at UC Irvine, so just a big fancy title means a whole bunch of stuff reports to me. Anyway, in this role, I'm also chair, as you heard this morning, of the Student Mental Health Oversight Committee and chair of actually the Vice Chancellor's Council, just taken over. But I'm now setting all that aside for a moment while I just go back to being a clinician and doing what I love and being a professor in the classroom. So it'll be my pleasure to try to excite you about a topic related to the conference of bringing us all together. It's something that I call clinical tools for cultural proficiency. And it asks the question about how do we narrow the gap between aspiration and actualization. Everybody with me? All right. Now, I want y'all to know that I showered this morning. I had lunch. So if you want to sit in the front row, it's okay. I'm not going to bite. It's all good, you know. All right, let's keep on moving. So we have a quick hour to do what ought to be like several hours worth of stuff. So I always start presentations with assumptions. And I want to start this one in the same way and share with you what assumptions I make about this thing we call cultural proficiency. And I want to use cultural proficiency intentionally today, so we'll get to that in a moment. First assumption I make is that if the foundation of our individual, institutional, organizational, and societal competencies are not anchored in values that contribute to the cultivation of the human spirit, then what we build will not sustain itself over time. Let me say that again. When I'm talking about competency, when I'm talking about whatever theoretical orientation you use, when we're looking at individual competence, when we're looking at organizational competence, when we're looking at institutional competence, when we're looking at societal competence, in all of those domains, what I'm arguing is that if the foundation of those competencies are not anchored in values that fundamentally contribute to the cultivation of the human spirit, then what we build in terms of a competency model is not going to sustain itself over time. Now, why is that important? Because one of the things we have to interrogate as clinicians is that so much of what we do is pathology driven. We are very good at diagnosing pathology, yes? But I want to invite you to consider that even if you look at the number one personality instrument still we use in the country today, somebody tell me what it is. MMPI, right? But MMPI, everybody knows that, yes? Validity scales, clinical scales, etc. Okay. So you have to, right? Just listen to the names for a moment. Hypochondriasis, depression, hysteria, psychopathic deviant, right? That's an anger scale, right? For those who don't use MMPI a whole lot. Masculine and feminine scale, we're still not quite sure what that measures. Paranoia, psychasthenia, that's anxiety, big fancy word for anxiety. Schizophrenia, hypomania, social introversion. Anybody see any strength in that? So even if you can come off and not exceed, right? Mean on those scales is what? Anybody know? What's the mean on the scale? Come on, clinicians, give me something. So are we using the 1 or the 2? Because you just told on yourself you're using the 2. You didn't think I knew that, huh? See, even when you're a vice chancellor, you still remember that kind of stuff. So let's go back to the 1 for the old school folk in the room. So mean was 50, standard deviation was 10. Now, why is 70 and 30 an important threshold? Somebody tell me. Because clinical significance is always achieved at 2 standard deviations from the mean, right? So whether we're using the new scale, right, or the old scale, all you have to do is know what the mean and standard deviation is and count 2 in either direction, and you know what's clinically significant. But even in all that, all we're looking at some point is the measure of pathology, the measure of depression, the measure of anxiety, the measure of how angry is this black man that just came into my center? How angry is this woman who just came in? And so you have to infer mental health from an absence of mental illness. That's not what that says. So in the Parham school of where I do my work, I believe that you can't have competency if, in fact, the foundation of your clinical intervention, the foundation of your competencies are not anchored in values that fundamentally contribute to the cultivation of the human spirit. Everybody with me on that? Okay, number 2. I assume that competency is nice, but proficiency is preferred. I'm not talking about just being competent and getting over that threshold like, whew, we made it. I'm talking proficiency here. 3rd, that legitimate theories of cultural diversity can never be anchored in constructs that fundamentally don't support and affirm the humanity of the patient populations you serve. So if you're working with Latino folk, if you're working with Asian American folk, if you're working with African American folk, if you're working with gay lesbian folk, if you're working with veterans, if you're working with whatever theory you are using, just pick one. If somehow they aren't affirming those populations and their humanity, then part of the question you ought to be interrogating is, why am I using a theory that doesn't support and affirm the patient populations that I see? And 4th, is training to be a culturally competent professional cannot be done in a single course or by reading a single book. Competency does not occur in 20 minutes or less without commercial interruption. Y'all with me? So I know it's as hard as we work, it's tempting to go out and say, I went to a seminar, I read Daryl Sue's latest book. I was hanging out with Dr. Choi, right? But one, right? And she was teaming with Dr. Mitchell, so we got a little multicultural thing going on. So, I went and I was like, right? One session is not going to do it. Competency really occurs over time, over experience. So we want to be able to get that out the way. Everybody with me on that? All right, cool. All right, so let's keep on moving. Now, I want to use a case study method today. So dribble a few notes if you'd like. So Roland is a pseudonym for our client we're going to work with today. Let me get back to the speakers. Okay. So Roland is a 29-year-old African-American male, self-identified African-American male, who resides in a medium-sized urban area. So imagine he's a transfer student, right? He's a little older than the typical 17, 18-year-old freshman who comes in, right? So transfer student who's coming to our campuses. He's been encouraged by his wife, so he's married, to seek treatment because they are concerned, both he and she, about his recent behavior. Listen to a symptom cluster. He's constantly on edge, frequently agitated and angry, and otherwise moody. He's also begun to spend more time away from home, involving himself in assorted activities like working out a whole bunch more than he used to, etc. This pattern has persisted for approximately 2 months and seems to coincide with a change in Roland's job 3 months ago when he was assigned a new supervisor. And Roland has been with the company for 4.5 years, but 3 months ago he got a new supervisor. Everybody with me on that? Okay. His new supervisor, who is he? 44-year-old white male, exhibits a management style characterized by very little encouragement, praise, or support. Instead, what Roland receives is constant critique, autocratic directives, feels that he's being constantly watched. Even though his work performance has been rated as good and he's been a steady performer, he now believes he's being targeted and unfairly treated because of his race. That's Roland. Okay, everybody with me? Okay, so how old is Roland? Single and married? Right, does he have kids? We don't know, right? Okay, how does he identify? African American. Okay. Presenting problem comes to you with what? Right. So irritability, on edge, change in mood over, right, how long has it been lasting? How many? How many months? Says 2 months. Right, I heard 3 and 2 and whatever, so about 2 months, okay. So important to be precise, that's why. And it seems to correspond with his job, okay? So clinical precision in this case, real important. So if you had to, right, say, I know what's wrong with Roland, what would you speculate? Stressed out by the new supervisor. Say that? 1 month honeymoon period with new supervisor, right? Honeymoon we ended quickly though, right? That's it. Other folk, what would you speculate? What's wrong with Roland? A little louder for me. So maybe adjustment disorder. Interesting. What's wrong with Roland?
It could be that he is experiencing discrimination, prejudice at work.
So maybe he is experiencing discrimination, prejudice at work, and therefore what? What's wrong with Roland?
Well, actually, he's healthy. That's what's
Right. So maybe he's having a healthy reaction to the social pathology that's existing in his life. Good. What's wrong with Roland? And maybe yes, maybe no. But see, these are the kinds of things that oftentimes present themselves to us and we have to speculate. Now, what all clinicians know, I think, is that we never come to a diagnostic conclusion, right? Our only question at this point, right, in the intervention is, what are the diagnostic what? Possibilities, right? Dr. J.O. in the house. All right. So when we talk about diagnostic possibilities, I want you to keep that in mind because it's possibilities that we're looking at, not necessarily conclusions. You want to be very, very careful, particularly for young clinicians, to think about making a diagnostic conclusion so early in your mind, even though you know a whole bunch of stuff. Because the diagnostic conclusion in this early in the intervention can be your worst nightmare. Now, in addition, what we know is that Roland has begun to doubt his own sense of competence and worth, despite believing that he does a reasonably good job. So those of you who were thinking about something else, he's oriented times 4 and looking to help resolve some of his emotional distress. He has no previous psychiatric history, denies any substance use, alcohol or drugs. Okay? Because some of the agitation he was experiencing early, how many of us were thinking, I'm wondering whether or not any drug use? Yes? Okay. So let's continue. So Roland's assigned to you for short-term therapy, and you agree to treat him, transfer student, on any of our campuses. Assume that you employ a cognitive behavioral orientation in his treatment. So according to that model, you got 4 questions. 1, what's the etiology of his distress? 2, what's the target of your therapeutic intervention? Because if you assume the etiology is X, then the target of your therapeutic intervention has to be X. Okay? 3, what is your role as a therapist according to that particular theoretical orientation? And 4th, what assumptions do you make about how and why change will occur in Roland's mood? Everybody with me there? Okay, let's see. Who's with me? What do you think? I'm going to turn this off so I can walk in front of this people. What do you think? What's the etiology of Roland's distress? What's the cause?
negative automatic thoughts about himself.
So negative
Automatic thoughts.
automatic thoughts about himself. Okay? What's the etiology of Roland's distress? Okay, could be the environment, could be his feelings, so the thought process. Okay. Okay. All right.
I would say there's a dramatic component to it.
So say some more about that, Dr. Mitchell.
That being confronted with a reflection of himself from his supervisor's work that is incongruent with his self-concept. And again, I think it's important to recognize that it's a supervisor, so this is coming down some hierarchy of some sort. Could be perceived as a type of trauma, emotional trauma, and that could be what's causing the distress.
Interesting. So now you have an individual who has an image of himself that is X, okay? Whose self-image has been assaulted by a misalignment between his view of himself and a supervisor who's constantly berating and critiquing that now instigates him now starting to doubt whatever this image is, right, that he set up. Let's go back here. Scream louder so we can hear you.
I'd just be curious about has he ever experienced anything like this before in his life? And, how he dealt with it, how he deal with it, you know what I mean? That's what I'd be curious.
So you want to know, has he been through something like this before?
Yeah.
And if so, what coping strategies did he use to kind of navigate that space?
Or him, or was there a community intervention? I would just want to know, has this happened before?
Okay. What's your role as a therapist in this model here? And I picked this one because lots of our centers use cognitive behavioral approaches. What's your role as a therapist according to this particular theoretical orientation? Mary Pat?
Well, from the model, I think feelings match what you think is happening. And so first it's to find out what he might be thinking, how he's experiencing his life that is supporting of the distress he's going through, and then exploring with him, because some of that's going to be accurate, maybe all of it. I don't know what percentage, but, depending on how close what you think is happening to the reality of what's happening determines what your coping options are. So if the fact is you're working for a horrible, abusive person and you end up with other options, you might want to explore other options. If the fact is you're not used to this new corporate culture, and the fact that you're getting feedback that you're doing a good job somehow doesn't register very hard, but every other little thing registers super hard, and trying to figure out, what's contributing to his take on things and trying to reduce excessive distress that's not based in reality, and that he's got real reality-based distress, look at coping options for that.
Okay, so in therapist lingo, the role of the therapist in this particular theoretical orientation is to manage the assumption that his emotional distress is caused by a belief system, right? So this is kind of the ABCs of how cognitive behavioral therapy works. His belief system is believed to create both the emotional distress and the behavioral, missteps that he's going through in his life. So the target of your therapeutic intervention then has to be what? His own, thought process to identify whether or not, even as you identify his belief system, is that rational, is it not rational, as he identifies thoughts about himself, thoughts about other people, thoughts about the situation that may in fact be there. We then move to try to figure out, okay, is this true, is this not true? We dispute, we affirm, and then we move to try to replace whatever we think is irrational with more rational stuff. So the answer to question 4 then is, what assumptions do you make about how and why change will occur? The assumption is, if we can confront some of the irrational belief system Roland brings with him into treatment, then what? We can help change some of his thought process, reorient the way he's thinking, so that he now begins to orient himself in a more positive as opposed to, a critical or destructive way. Just interesting assumptions, so let's just lay that to the side for a minute. Now, if we look at Roland being an African-American male, part of what we have to interrogate when we think about clinical tools for cultural proficiency is, what are some of the culturally specific questions? And one of the questions I would invite you to consider this afternoon is, what theoretical assumptions are made that may run counter to Roland's cultural worldview? What is likely to be the cultural worldview of, in this case, an African-American client? It could be Latino, could be Asian, could be gay, could be whatever. And how do those run contrary to whatever theoretical assumptions that a cognitive behavioral model might make? To be clinically proficient, you've got to be able to interrogate that question. Secondly, what factors or variables might inhibit or facilitate the process of therapy, given that he is culturally different? Third, what do you know about cultural manifestations of psychological symptoms, and how might that change your diagnostic conclusions and treatment strategies? So what do you know about depression, and black folk? And can't nobody black answer this question. What do you know about depression? Anybody? How does depression oftentimes manifest itself in African American folk? Say that? So maybe more physical symptoms, like, describe that for me, user. Right, so oftentimes you'll find somatization of symptoms. So absolutely very true. And you find in a lot of folk, even though it's difficult to qualify and put we ain't talking about everybody black on the whole universe, right? But that's certainly one. What else? Say that? So, but hypertension also would be an extension of that physical manifestation of that. So we see the high blood pressure, hypertension stuff, absolutely true. But what's true, so short answer to the question, because we only have an hour here, is that oftentimes black folk in a cultural ethos learned, much like you do with the preacher on Sunday morning, because everybody comes to church with, right, some tragedy, some trauma, some, right, craziness in their life. And the preacher, he or she, is very good about saying, while it may be darkest in the night, when the morning comes, everything gonna be all right. So they get taught to keep on keeping on in the face of adversity. So while we're used to seeing the normal vegetative signs of depression, describe them for me. Right, lethargy, difficulty concentrating, difficulty eating, whatever, low energy, not getting out the bed, whatever. Black folks sometimes are 180 degrees different than that. They don't slow down when they get depressed. They do what? They speed up. So oftentimes the agitation that he'll feel, now I'm going to work out 15 times a week when I was only working out 3, right, is oftentimes a manifestation of how they express that they in fact are starting to get depressed. So it's oftentimes, just as a quick example, what we have to know about the cultural manifestations of psychological symptoms, because they may not look the same in somebody who's black from somebody who's Asian, from somebody who's Latino, from somebody who's Caucasian, from somebody who is from the Middle East somewhere. Fourth question, what is the standard of normality for African American people, and how might it be used to assist the client in achieving some sense of healing? Let me ask that question again. What is the standard of normality? Now, why is this one important? So I challenge you all on this one. We are the healers, as I mentioned this morning, yes? Our job is to restore somebody who has some degree of mental debilitation, be it mild, moderate, or severe. Our job is to restore some level of wholeness and healing, to help him to be more mentally healthy. Yes? So my question is, how can you, as clinicians, help someone like Roland to be more mentally healthy if you have no idea about what constitutes mental health for African people? These ought to be things that make you go, Think about that a minute. How do you define mental health, and what is mentally healthy for somebody who's black? Assuming they even identify, which we know Roland does, with being, right, African American. And that's not to say that all black folk think alike. They don't. But assuming that he adopts a cultural worldview that is consistent with that, do our standard definitions of what is mentally healthy in the kind of democratic sanity way in which we define mental health suit Roland's mindset, and would that serve us well as clinicians if we were looking to restore him to some level of health and wholeness, if we can't identify and define what constitutes mental health for somebody like Roland? Gene?
I also think, given the context of what's happening right now in our nation, that also being a black man could have a specific context as well as to what is going on in terms of mental health.
Oh, absolutely. So this is Roland, who when he takes the MMPI is going to come out very high on scale what? Right. 4 for sure. Right? And probably 6. Right? Not sure he would show up on 2. Right? Because it doesn't always manifest itself the same ways. And as I look at the items, right, all 525 of them, some of the ways in which they describe depression don't necessarily align with the way in which, he would identify with. But his F score, unconventional thinking, 4, 6, and probably 8 would be high and elevated. That's typical for most African American folk we see. Why would 6 be elevated? Because there's a question on 6, things like, sometimes I believe people are out to get me. Like, why would somebody black and male in America thinks somebody was out to get them. As soon as he checks true, right, he comes up as a false positive on, right, our paranoia scales. It's that kind of, right, thing that we have to know to be able to understand and work with the clients we have. Now, I want to move on because as we reflect on the questions of the case study, I want to turn our attention to just a couple of principles. Uh-oh, what did I do? I don't know what we did. You had a similar problem? Oh, it's a conspiracy with the black man now. No. So, it's Taisha's computer, so this is still in.
Let me see what kind of PowerPoint it takes.
I don't know what we did or didn't do. All right. All right, let's keep on pushing because our time is short.
I'll take a look at it.
So we'll go to plan B like we used to be the old school teacher. So what I want to invite us to consider as we think about the case of Roland is how do we help define this notion of competence, okay? And how do we move them from competence to proficiency in terms of clinical tools that might help us get to some of this space? So, competence. Competencies, for those taking notes, are nothing more than a set of traits or attributes that allow us to effectively intervene on the demands of a particular situation or circumstance. Let me say that again. Competence and competencies are nothing more than a set of traits or skills or attributes that allow us to effectively intervene on the demands of a particular situation or circumstance. It means that if I want to produce a certain outcome, then those skills allow me to achieve, right, what I desire. That's all we're talking about when we talk about competence. Now, I mentioned competence because lots of people are talking about multicultural competence and trying to do competency work, etc. And so I appreciate the notion of competence, but what I'd like to do is to think about introducing folk to a 4-tiered model of competence rather than a bimodal distribution where you're either incompetent or not. Okay? So, first tier, if we had my slides, would be incompetence. So, if you're reading a chart, and I'm going to have you do this, I want you to try and go across the top of your page with just dividing it into 4 sections, leaving a 5th column on the far left to go down. Okay? So, first column going from left to right is incompetence. I think there's some things we do where we are incompetent. What do I mean? I mean that we lack both the awareness and the skill. So I don't know what I don't know, and I don't know how to do what I need to do to achieve whatever therapeutic outcome I'm trying to achieve. Incompetence. Secondly, across the middle, I think you can be pre-competent. Pre-competent to me, as I talk about, here are clinical folk. I don't know what happened, but somebody in here breathed, and it just like, no. So, pre-competence. Pre-competence is I have the awareness about what I want to achieve, but not the skill base to be able to get that outcome, right, accomplished. Pre-competence. You then have, thirdly, moving across the page, competence. So competence, what I just described, is having, right, the awareness and skill a set of traits or attributes that allow me to effectively intervene on the demands of a particular situation or circumstance. That means I have both the awareness of what needs to be done and the skill to be able to get that done. Okay. And fourth now, so all the way over to the far right, there's a column called proficient. And this is one I want you to put an asterisk by. Because what I want to try to do is encourage folk that we need to try to be more proficient at what we do. And that means that I can be competent with a standard of excellence consistently over time. Proficiency is about competence with a standard of excellence consistently over time. Now, instead of doing incompetent, competent, what we're looking at is now going through at least a 4-stage process. So I can first be what? Incompetent. Next, pre-competent. Next, competent. And next, and proficient. Okay, now, so imagine now we're going down the skills. This is your left side column of the page. And we're thinking about specific therapeutic skills that you could employ that would allow you, right, to illustrate that. So what's the first thing we try to do in our clinical work? Client comes in like rolling. What's the first thing we're looking to do? Establish rapport, build trust. So I call that as a category connecting with clients. First thing we want to do is connect. Now, the best people at connecting sometime, want to know who they are? Who are the best people at connecting with clients? Say that. Practicum students, right? The reason that is, right, is I talk to Francis a lot when we train interns. The reason that is why? Dr. Diaz, why?
They got nothing else to rely on.
Right, because that's all they know. All they know is how to establish rapport and build trust. They don't have any clinical sophistication. They don't know a whole bunch about theory. Don't do MMPIs. Don't do, what they know is about how to establish rapport and build trust. But I would argue, and so I would invite you to test this out if you ever videotape some of yourselves and do that for, just peer review. The more clinically sophisticated we get, the less time we spend on establishing rapport and building trust. So now it's, hi, I'm Dr. Parham. How are you? Have a seat. What brings you in today? And that's the extent of our establishing rapport and building trust sometimes. Because if you're in private practice, we got forms to fill out and mandates to meet and other kind of information to get, and we have this kind of 50-minute hour for clinical intakes and other stuff we have to try to get through. And then we wonder why somehow people don't come back into our clinical spaces. And I hope it doesn't get that way, but sometimes it does. Oftentimes what I will do as a clinical technique is I will have a client come sit in front of me, like Brian here, and I'll have my little clinical notes that I've gotten from our trustee, right? Point and click, right, online. So as we then get to clinical notes, and we have a whole bunch of information on the client, and the client knows how much about you as a clinician? Zero, right? Other than your name or so-and-so, even though sometimes they may not even know that, because they sometimes don't know who they got hooked up with when they made the appointment, right? So oftentimes what I will do is take this and set it aside. And whether it's on paper or electronic, I set the clinical notes aside. Because what's most important in the moment, what's the skill we're trying to illustrate here? What's the category? We're connecting with clients. So if I'm trying to connect with a client, then oftentimes what I will do, particularly for clients who are culturally diverse, particularly for clients who are culturally diverse, is I'll say, look, Brian, I know an awful lot of stuff about you, right? And I appreciate you being able to share that, but I'm aware you know nothing about me. What's important for you to know about me in the moment that would help you feel more comfortable at sharing some of the information that I'm going to need to ask you about and things I'm going to need to kind of, question you on? Stop right there. What am I doing?
Making a dialogue.
So we're now trying to have a dialogue, but what am I doing? What's the ultimate benefit of something like this? Yes. Say that again. Right, so it diffuses the power differential to start. Very good. Right? It allows us to normalize a relationship. It takes it down from I'm the doctor and you're the patient to we just people trying to communicate, right? So you may have 2, 3, 4 questions. You may have 2. You may say, wow, nobody ever asked me that. You'll kind of freak your clients out by that. But remember, all I'm trying to do in the moment is what? It's connect. It's try to hook him. It's try to say, wow, this person really cares about me, because that's what's going to bring me back into this particular, right, counseling center, into this particular psychiatry office, into this particular space, so that I can just connect with a client. I can tell you for sure that is very, very important with clients you work with who are culturally diverse. Because if you can't establish a relationship and a rapport with them, right, it is going to be very difficult to be able to hook them. Ha ha. Oh, promises. No, okay. All right, let's see. So, good. Okay. So, if we pick up on the screen, what I want to do is pick up where we just left off with Brian. So, Brian, I'm not abandoning you. I'm just transitioning. So what I'm trying to do is connect with a client, first of all. What I'm trying to do is do competent assessment. So we're going down the left side of your page. What I'm trying to do is facilitate awareness. What I'm trying to do is set goals. What I'm trying to do is take action and instigate some change. And what I'm trying to do is then circle back around to have some feedback and accountability. So in this particular space, when we connect with a client, what I'm arguing is that connecting with a client, particularly that is culturally diverse, has to go beyond a handshake. Let me borrow you, brother. What's your name? Marty. Come on up. Thank you for volunteering. Now, have a seat in the client waiting room. So when I walk in behind whatever door, right, to receive my client, right, and I walk in and I'll say, Marty, how you doing, brother? So we might step up. Now, this is Mario. Okay, so Mario. So as we walk in and we have an alignment here, what might we do? Because some of y'all have seen me do this like in a videotape and everybody goes, oh. So stand up from me. So if a brother's greeting each other, how do we typically greet? We do this. Stop. This is a violation in somebody's book. Why?
Boundaries.
Right, because now you're touching, you've now violated boundaries, you've now whatever. Part of what you have to do, what am I trying to do with Mario here? Connect. So sometimes you can feel out, right, the style and the vibe and the substance. You can just feel the spiritual energy that's coming, because that's just the way folk normally do. And I'm not saying if it don't fit, don't force it. So if this works for you, then fine. But with some folk, it doesn't. It doesn't touch them in an authentic way. And if you want to get some culturally different folk to feel more authentic, like folk care, what I just demonstrated with Brian, what I'm demonstrating with Mario here, where they do this, is the way in which people connect. And that is sometimes what you have to think about doing, even though, thank you, your APA manuals will tell you, violation. Our ethical codes have great parameters around thou shalt not. And thou shalt not do this and that. Because part of the reality is they want clinicians not to exploit their clients. Yes? Believe that. But the assumption they make is that somehow, since your intent is to exploit your client, then I'm going to put a bunch of prohibitions in, like boundary issues and whatever, that is so Eurocentric I can't stand it sometimes. Because in a whole new set of ethics, related but different, that I embrace, like the Association of Black Psychologists, it says, certainly clinician do no harm, but it also says, do what is most facilitative in the moment for the client. And what I'm trying to do is be a healing presence in the moment. And if a healing presence means that in order to connect with him, that we are engaging in some level of authentic touch in the way in which men do, that becomes facilitative in a moment. And we can't be so anxiety-provoked and afraid of textbook theories that haven't been proven in practice and allow that to constrict what it is that we might do in a client session that might bring a client like Mario Ryan back for time 2 or 3 when right now they aren't coming back after time 1. We are connecting with clients. Y'all feeling me? Okay. When we do competent assessment, you've got to be able to find a way to identify cultural strengths, not simply pathology. And most of our assessment instruments don't. And as I argued in the beginning of the presentation, that if in fact the theories and instruments you're using do not fundamentally affirm the humanity of your patient populations, then you've got to try something different to try to find out who they are at the authentic core of their being. When we're talking about clinical tools for cultural proficiency, you cannot be culturally proficient only accessing pathology and not know anything about strength. Because it is that strength and resilience that you're going to have to rely on way down here when you instigate change, that is how they're going to keep on keeping on in the face of that adversity. So let me move through the model because I know we're running on time and I want to leave a little time for dialogue. The third phase of the model is facilitating awareness. And what are the techniques we can use? Sometimes I use things like rephrasing. There's an old piece of African wisdom I've stylized over time that says that life at its best is a creative synthesis of opposites in fruitful harmony. Let me say that again. Life at its best is a creative synthesis of opposites in fruitful harmony. It has a lot of different meanings, but one of those is sometimes your greatest strength can also be your greatest weakness. Sometimes your greatest weakness, your greatest strength. So how many of us have been with a client who comes in, and what's wrong today? Well, Doc, my relationship is just so bad. And then they begin to just pour out in cathar about how bad stuff is, yes? So if we think about emotions and looking at how we empathize with clients, what we're good at doing as clinicians is classifying emotions on domain and intensity. Domain being positive and negative, intensity being low, medium, high, yes? So when I come in, I talk about how bad this man was or how bad this woman was, and they were blah, 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 blah. What's my domain? Negative or positive? Negative. What's my intensity? Moderate to, right? Severe, right? Now, severe will get into the I'm crying and I'm, right. Okay? But if you step back off of those particular clients for a minute, in order for me to feel that bad about a relationship that I'm involved in, what does it also say? Say that, Mary Beth? It might not say I care anymore, because I don't. As bad as that person been, but what does it say though? At one time, right? That I had to care. That in order for it to feel negative 8 out of 10 now, then what? It had to have felt positive 8 out of 10 at some point. So part of helping clients, what I call creatively synthesize opposites in fruitful harmony, is helping them understand that the challenges and the adversity that they go through in life might in fact also be related to those kind of positive things. Why is that important? And it doesn't help you ignore the pain that they're going through. You've got to be able to deal with that. But I see so many people who come out of therapeutic interventions where they're dealing with relationships who are no better able to now receive a positive blessing in their life with a new relationship because they're still so angry because all they did in therapy was cathartic. They didn't heal. Let me say that again. They catharted, but they didn't heal, because you can't heal them until you can move them into that positive space with where they're going. So part of what these therapeutic techniques are designed to do, right, is to help people move toward those things. I think reflecting is some of the stuff we use. What about the use of metaphor? Anybody use metaphor in therapy? Right? The use of metaphor, I think, is a particularly strong technique, partly because it becomes an interpretive lens through which to look at how they perceive the metaphor. What are some of the ones you use? Anybody got one for me? What do you use? What do you use?
Trying something new. It's like walking into a jungle with no path. And the first time you do it, you got to cut a lot. And the second time, there's a little more of a path.
Oh, man. Good. What else? What do you use? What do you use?
Boxing match. You're going to take some hits, do some rounds.
Life is like a boxing match. You're going to take some blows and lose a couple of rounds, but what? You got to go through the pain. Out of pain comes love. Out of that fight comes the victory. Okay? Good. What else? What do you use? Mary Beth?
Basketball shot, like the newer you are at it, the worse you're going to be, and even the best miss a lot of shots.
Good. Best shooter in the NBA don't shoot but 47%. Right? You're going to miss more than half of what you got. But if you stand there and just practice doesn't make you perfect. It just makes you what? Better. So whatever the metaphor you're using, I think metaphor can be effective in the context of therapeutic intervention. Now, when we think about setting goals, so much of psychology invites us to be what we call a objective outsider. Culturally, I want to invite you to think about being a subjective companion, not an objective outsider. When you went to grandma, when you went to Mrs. Jones, who was the third grade teacher, when you went to, Mr. Simmons, who was the barber down the block, because those are the reservoirs of where therapy gets done in black communities sometimes when they don't rely on trained clinicians. You can't just walk into one of those spaces and say, well, I got an issue with that. And they say, well, child, just be all you can be. They have some very deliberate advice for you about what they expect and how you ought to do, including telling you, not what I'd recommend. Might want to rethink that, child. What the heck were you thinking? Like, no, you need to be going in a different direction. Who's heard that before? Yes? And you didn't get traumatized by that, did you? And sometimes you love the fact that somebody cared enough to be able to tell you the truth rather than doing that, even though you wasn't trying to hear it in the moment. Well, I think becoming a subjective companion is a posture we don't assume very much in therapy because we're always too used to being the objective outsider. And I'd invite us to think about doing that. I think reframing the environment while teaching improvisation, transcendence, and transformation, meaning sometimes it just be like that. And you can't help people engage it because it's just too big and bad a line to be able to beat. So you just learn to transition. You transform it if you can, but you transcend it and just rise above it and keep on moving on. And just be like that sometimes, is what the brothers on the corner would say. I would also invite you, as you think about setting goals, to help clients have a culturally corrective experience. Everybody with me on this? What is a culturally corrective experience? Who remembers Correctol? Who remembers X-Lax? Who remembers, right? What is a culturally corrective experience? Assume that therapy ought to parallel the law of digestion in the human body. Your physical organism is like a magnificent machine because it has the ability to ingest food and nourishment and, right? Other stuff, substance. Process it. Discriminate that which is good and store it. Expel that which is bad and take it out. Where do we do that in therapy? Part of what you've got to be able to do, particularly for folk who are culturally different, is help them have a culturally corrective experience where they got to be able to analyze all that stuff you've been taking in. Keep that which is affirming to your humanity and literally poop out the waste, the craziness that you have absorbed. And whether you're using a cognitive behavioral framework, whether you're using a gestalt, right? Whether you're using a psychodynamic and trying to go back to some developmental issues in childhood and whatever you want to do, okay with me. As long as what you end up with is being able to help your clients have a culturally corrective experience. Once you then set the goals, you've got to be able to think about taking action and instigate change. So you've got to be able to empower your clients through self-knowledge. Self-knowledge. Man, woman, know thyself. By the way, that was a dictum that was carved on the temples and tombs long before, right, Greece and Rome were on the planet back then. It precedes them by thousands of years. Who are you in the context of that? And then always making sure you put in a feedback and accountability loop. Now, as we think about these 6 stages of therapy, which are outlined, by the way, in a book I wrote 2002 on counseling persons of African descent. We also wrote a book with a couple of my multicultural colleagues, Miguel Gallardo, Joe Trimble for the Native American folk, and Christina Ye, who did the Asian American piece. I did the African American piece. That's called Culturally Adaptive Counseling Skills. It came out around 2012, I think. It's in that book. So what it looks like then is as you move from those particular things we want to do within a therapeutic intervention across these domains of incompetence, pre-competence, competence, and proficiency, you should be able to come out with a template that looks something like this. If we're going to talk about clinical tools for cultural proficiency, you cannot be effective and a better clinician by simply deciding that you're either incompetent or not. Because I think you can be very, competent on doing a couple things and incompetent on another and very competent and proficient on others. And so part of what I would encourage you to do, both as individuals as well as people who are working with staffs as you do peer review, is to think about designing templates like this for your people and use them as a staff to say, given this, where are we both individually and collectively as a center? And given what we're already good at, let's keep doing that, but where do we need to grow? Where do we need to get better at? Because those are the things I think that are going to try to pull us in. So as we talk about this notion of clinical tools for cultural proficiency, what I want to do is invite you to look at a competency assessment that looks at the areas of competence across these particular skills and techniques. And I've only, like I say, listed 6 categories. There are probably a dozen others we could find. And fill out those. So many boxes you have to put up and down would, I think, be good. But that's what I'm encouraging folks to be able to do to try to better illustrate what ought to be the tools for cultural proficiency. Because that, I think, is what is going to allow us to be more effective at working with some of the client populations that we work with. So as we think about going through a normal intake, and whether we have the electronic records or not, we all should, they're all looking at these same things. Identifying information, what's the presenting problem, what's the relevant history. And here we're talking about the history of the problem, family background, prior mental health history, substance abuse, any medication they currently take. You're then moving to do a conceptualization both from whatever theoretical orientation you have and the diagnostic nosology we use, which is now, DSM. We then make recommendations for treatment and then come with some kind of disposition. Well, part of what you've got to do in a template like this is not just teach folk how to do this when they come in for interim and practicum, but you've got to also think about how do we apply some of the cultural information that might impact how we get identifying information. What cultural techniques can we use to more fully flesh out what is the presenting problem? What cultural techniques can we use, particularly one, let me put an asterisk by this one, because the presenting problem here for somebody like Roland is not just intrapsychic. It's not just that Roland is agitated. It's not just that Roland is anxious. It's not just that Roland is depressed. It's not just that Roland is angry. Roland is reacting in some cases to a normal reaction to what you ought to be doing when you run into that kind of social pathology in your life. Now, is it possible that Roland might be totally paranoid and he made up all that stuff? Possible. So you can't exclude that in any circumstance. But what you can't do is just assume that Roland's stuff isn't like that, because you've got to help him, to feel more empowered to make some systemic change and not just believe that somehow it's wrong with him. So if I can just fix the way he is in his head and help him to be less depressed and send him back out into the workplace, things are going to be better magically, because they aren't. So we've got to think about how we not just look at this information, but how do we apply cultural information in these particular spaces. You've got to be able to look at the cultural manifestations of the theories and where they violate and don't violate. You've got to look at categories of the DSM and find out what fits, what doesn't. What passes for cultural competence in the DSM is comical. It is absolutely comical. And I was one of those people who, along with the Association of Black Scholars and other folk, who looked at the drafts they sent out and the information we sent back and what actually made the cutting floor on the last DSM. It is comical to me. It's better than what it used to be, but it's not even close to being what I would call culturally competent or proficient. So we just have to be careful with how we decide to use those things. And any recommendations for treatment that we employ also have to make sure that we do that. But if we had to do anything, what I want to do is spend less time inviting you to be better at this, even though that needs to happen. I want you to spend more time up here. Because when you establish the rapport, that build the trust, do those kind of things that are way up in here, that is what is going to hook these clients to come in to say, yes, I can trust that what you're providing for me is beneficial, worthwhile, and it will make a difference in my life. And if you can get them to believe that, then they'll give you lots of this other information here. And hopefully you'll see a level of consistency between what our clinicians will find in counseling centers, what our psychiatrists will find in our clinical centers and student health centers, and to do that. I close with one of my Parhamisms. An opportunity is a threat if you only predict failure, but a challenge if you think we just might win at this. If you think we can be more culturally proficient, if you think we can learn a few more clinical tools to help ourselves be more culturally proficient, then I think that becomes a best practice we all want to employ within UC. Who thinks we can be a little better? Yeah? Now, my goal is you leave this workshop, and I say this as humbly as I can. I don't want you to go out of here being 100% better on 50 things. That's too big. That's like that New Year's resolution we all make and nobody remembers what you made 3 months later, yes? If I had any goal for you, it's not to be 100% better on 50 things, but can you be 5% better on one dimension of cultural competence? And if you could be 5% better on cultural competence and add up all the 5% we represent, we could literally transform the way we do therapeutic intervention with culturally different populations overnight. Who's willing to give me 5%? Who can give me just 5%? Yeah? An opportunity, my friends, is a threat if you only predict failure, but a challenge if you think we just might win. With that, I'll stop and say it's been my pleasure. Apologies for the technology, but it's been real. Thank you.